Hello. Good afternoon, everyone. Welcome on my live stream lecture discussion for today. Identification of infectious disease processes. My name is Irene from Infection Control Department. Again, would like to welcome you on my topic discussion for today. Again, it's about identification of infectious disease processes. To my co-staff, medical staff, nursing staff, hope you understand today what I will discuss. And this is already part 3 and 4. The part 1 is already discussed last week ago. And this is only for continuation. In part 3, I will discuss in my part 3 lecture, I will discuss the viral hepatitis. You will know what is Hepa A, Hepa B, Hepa C, Hepa C, Hepa D, and Hepa A. That's for our viral hepatitis. And the last one is our human immunodeficiency virus, which is called HIV. Okay, let's start for this. For our first topic, let's share you in the screen. Let's start. The identification of infectious disease processes. This is our part 3, continuation. The viral hepatitis. Hello. Okay. The key concepts, currently 5 hepatotropic viruses. The Hepa A, B, C, D, and E are responsible for viral hepatitis. Hepa A, B, and C are the most common. Okay? All 5 can cause acute inflammations of the liver. Infections with hepatitis A and hepatitis E are usually self-limited. Hepa A, B, and C. Infections with Hepa B, Hepa C, Hepa D can lead to chronic lifelong infections. The chronic hepatitis B, C, and hepatitis D can lead to what? The cirrhosis, liver failure, and hepatocellular carcinoma. The HEPA A and HEPA E are transmitted via contaminated food and water. Saan to nakukuha? Sa tubig at sa pagkain. HEPA B, HEPA C, and D are transmitted by blood, sexual contact, exposure to contaminated equipment, and from mother to infant during childbirth. Breaches in infections prevention practices may lead to increased risk in exposure to the hepatitis viruses. Okay, vaccines are available for hepatitis A and B. No vaccine are available for Hep C, D, and A. Okay? And what is the key? Your prevention. Again, vaccines are available for Hep A and Hep B. No vaccines are available for Hep C, Hep D, Hep E. And prevention is the key. Okay, let's start for the hepatitis A first. So it's the first topic because Hep A. That's why hepatitis A. Okay, hepatitis A transmission. Transmitted principally by the fecal oral route. How to transmit? By means of fecal oral route. So you must care for this fecal oral route. With the highest level of virus in the feces found in the 2 weeks prior to onset of jaundice or liver enzyme increase. This is also the period of highest infectivity. Then transmission is facilitated by intimate personal contact. For hygiene, unsanitary conditions, or contaminated water, milk, or food, especially the raw shell fish. Our additional risk factors include childcare exposure, children, parents, or attendants. Intravenous drug use, travel to an endemic area, chronic institutionalizations, HAV is rarely transmitted by blood or blood products. Clotting factor concentrates as a consequence of transient viremia in asymptomatic donors. Again, hepatitis A virus is rarely transmitted by blood or blood products as a consequence of transient viremia in asymptomatic donors. Pathogenesis. What is pathogenesis? Pathogenesis is the manner of development of a disease. Okay, is the manner of development of a disease. In Tagalog, paano mo nade-develop yung isang sakit? Paano siya ma-develop? Okay, pathogenesis. Infection with HIV virus occurs in the gastrointestinal tract, transiently detectable in blood as early as 4 weeks before symptoms. Detectable in feces 2 to 4 weeks before 1 to 3 weeks following the onset of jaundice. Infected neonates may shed HIV, hepatitis A virus, and feces for months. There is no chronic hepatitis A virus carrier state. It replicates in cytoplasm of hepatocytes and then is shed in bile, which results in high titer of infectious Hepa A virus diseases. Disease occurs as a result of host immune response which causes hepatocyte injury, development of antibodies to hepatitis A virus confers lifelong immunity. The clinical features of Hep A infections is unapparent in 70% of young children under 6 years of age. In older children or adults, infection is typically symptomatic, with jaundice occurring in more than 70% of patients. Incubation period average 4 weeks, range 15 to 50 days, and might depend on inoculum size. Prodromal preecteric symptoms are nonspecific. This including the malaise, fatigue, anorexia, nausea, vomiting, abdominal discomfort, arthralgia, myalgia, and fever. And this phase lasts 1 to 2 weeks. Ecteric phase is notable for jaundice, dark urine, pale colored stools, pruritus, and anorexia. But resolution of prodromal symptoms lasts 1 to 4 weeks. Alanine transferase, and other hepatocellular enzymes and bilirubin levels rise and then generally recover completely over 2 weeks to 6 months. The laboratory diagnosis. Uh, the clinical features of acute hepatitis are not specific for hepatitis. virus infection. So, serological diagnosis is necessary. Again, serological diagnosis is necessary. Immunoglobulin antibodies to hepatitis A virus, which is IgM anti-HAV, are used to detect acute infections, detectable within how many weeks? 3 weeks of exposure, and are present at the onset of jaundice. Titer declines over 4 to 6 weeks, and it is usually not detectable after 6 to 12 months. Immunoglobulin anti-HA, the IgG anti-HA is also detectable at onset of jaundice and remains positive lifelong, indicating immunity to hepatitis virus. Yeah, and that's the clinical illness. There's the pattern for this. And you can see the chart. There is a this one. Okay, per week. And then treatment, supportive care, or your fluids in nutrition is the only known management for acute hepatitis A. Again, fluids in nutrition is the only known management for acute hepatitis A. Transplantation should be considered in the course of fulminant hepatic failure. Yeah, this is the prevention. Public health and personal hygiene measures, including hand washing or hand sanitizer. So, the number of preventions that we mentioned here is your hand washing or using your hand sanitizer. Standard precautions are appropriate to prevent HA, healthcare associated transmission in most instances with incontinent patients, undiapered or incontinent patients. The addition of contact precaution is recommended. The false exposure prophylaxis should be considered in instances such as household or sexual contact or in outbreak situations such as common source exposure. In an infected food handler or a case of Hepatitis virus in a children and a child care center. Hepatitis A virus vaccine is recommended for unvaccinated adults age 40 or younger with recent within 2 weeks exposure to hepatitis A virus. For persons over 40 with recent within 2 weeks exposure of hepatitis A virus, immune globulin is the one asked by last time by our one of our staff. Exposure of hepatitis A virus, immune globulin is prepared over vaccine. A dose of how many? 0.02 ml kilogram intramuscular IM. Huh? Protects for up to how many months? Protects for only 3 months. Huh? The local health department should be notified immediately about the case of hepatitis C so that tracing and prophylaxis of contact can be initiated promptly. 4. International travelers going to endemic regions, hepatitis A virus vaccine should be given prior to departure. For those over 40 or higher, a higher dose, of course, ml, 0.06 ml. So that's for adult. And consider as an alternative to Hepatitis virus vaccine prior to travel. Although this is not routinely practiced. When you travel today, I had cost of good travel uh, in our place in Philippines. The first day they will ask in the airport is your complete vaccinations. This is mandatory before you travel. If not, I think you need to complete it first. Active immunizations with either licensed single antigen (HEPA-A) vaccine, Habrix manufactured by, or combinations of generics which contains both HEPA-A virus in a lower dosage. Next, what is next? This is your hepatitis B, the most common. Hepatitis B virus is a small DNA virus in the family of Hepa DNA radial Hepa B virus. Overproduces envelope proteins. Okay. And what is DNA? This is your deoxyribonucleic acid. Sorry, deoxyribonucleic acid contains the genetics code of organisms. Includes what? Animals, plants, protists, algae, and bacteria. And then each cells in the organism tells what protein makes. Huh? They do not code protein sequences. This is the meaning of DNA. And what is DNA? Okay. Detection of these components or host antibody to HBsAg, HBAAG or HBsAg are used to diagnose and monitor acute and chronic hepatitis virus. Historically, Hepatitis virus was the most common blood-borne pathogen with risk for healthcare practitioner. The incidence of Hepatitis virus among healthcare practitioners dramatically fell in the 1990s because of preventive measures mandated by the OSHA blood-borne pathogens rule of 1991. The transmissions of Hepatitis virus parenterally transmitted through blood or blood products, sexual contact, or perinatal exposure of an infant. Its VAG positivity is associated with increasing infectivity. Low prevalence areas such as United States principally transmitted by sexual contact or IV drug use in a less efficiently transmitted by contact with saliva or mucosal surfaces. It's detectable in various body fluids that may be infectious, including blood, semen, vaginal secretions, saliva, tears, cerebrospinal fluid, ascites, and other serous fluids. The pathogenesis. The host immune response is more important than hepatovirus cytopathic effects on hepatocytes. During acute hepatovirus cytotoxicity, lymphocytes initiate liver injury, followed by antibody-mediated immunity. Mutant hepativirus strains may escape otherwise protected immunity or cause more severe or chronic infections. A majority of T cells immune system children immunosuppressed hosts might permit chronic hepatitis virus infections. Development of surface antibody, anti-HBs, and clearance of HBsAg denote resolution of hepatitis virus disease, leading to durable protection from reinfection. The hepativirus circular DNA does not need to integrate into host DNA to complete the viral life cycle, but when it does, it may act as a mutagen that drives the development of hepatocellular carcinoma. And here are the clinical features. The incubation period range from 30 to 180 days, means 75 days. The incubation period range from 30 to 180 days, means 75 days. Prodromal urticarial rust, arthritis, and fever occur in 5 to 10% of adults. Neonates or young children are usually asymptomatic. Acute hepatitis virus is more insidious and prolonged than hepatitis A virus. Fulminant hepatic failure is rare, but can be fatal without liver transplantation. Okay. And the symptoms resemble for hepatitis A virus. In acute hep B virus, HBsAg, and hep B virus, DNA are detectable in serum 2 to 7 weeks before onset of symptoms. When symptoms occur, immunoglobulin and anti-HBV core, IgM or anti-HBC, and the aspartate aminotransferase, which is your ASSD, and bilirubin levels all rise. ALT levels generally exceed and are usually elevated 10 to 20 fold from normal. Bilirubin elevations vary with severity. Prolonged prothrombin time, international normalized ratio, 1.5, or hypoalbuminuria implies severe hepatic injury and might protect fulminant hepatic failure. Acute hep B virus resolves slowly, weeks to months, following detection of immunoglobulin G and anti-HBC, IgG anti-HBC. Yeah, this is a typical serologic course of acute hepatitis B virus infections with recovery symptoms. The hepatitis B E antigen antibody to HBeAg, and then antibody to hepatitis B core antigen, hepatitis B surface antigen, the immunoglobulin and antibody to HBsAg. And there is clinical symptoms appear. The clinical symptoms appear. The HBsAg, the ABAG, the IgM, then the HBC and HBV DNA. Months after Hep B virus infection, and there is a pattern display. You can check this. The chronic Hep B virus with persistent HBAG. Okay, and this is, and we have here and the pattern for the legendary colors, coded colors that it is to you to locate per weeks after exposures. That's the titer. This is the calculation in the titer. The clinical outcomes of Hep B infections, acute hepatitis B. 90%, 9%, 1%. If 1% fulminant hepatitis, 9%, it's BSAG plus 4, 6 months, 0 to 6 months, 6 months, and then 90% resolutions. There are 50% resolutions, the asymptomatic carrier state, and the chronic persistent hepatitis, and chronic active hepatitis, cirrhosis, hepatic cell carcinoma, and the extrahepatic disease polyarteritis, dosing, and glomerulonephritis. This includes for your pathway from chronic persistent hepatitis. And I have legendary colors here so that you understand the percentage first. We'll start for the percentage and then how to the outcomes, the clinical outcomes of this hepatitis B infection. Okay, for the treatment,
Want to ask you about
sorry guys because they are school already started, but they can already post in the group of our WhatsApp group. In my infection control group, hospital. Okay, for the continuations, treatment for acute Hepatitis B virus, only supportive care is indicated. Hepatotoxins such as acetaminophen should be avoided. Again, only supportive care is indicated. Hepatotoxins such as acetaminophen, acetaminophen should be avoided. For fulminant Hepatitis B virus, liver transplantation is often required. Is often required. Often. Of- In chronic Hepatitis B virus, the treatment options include regulated interferon alpha 2A, adifovir, entecavir, and telbudin, and tenofovir. Now we are discussing for the treatment of this Hepatitis B. Regulated interferon is a subcutaneous injections, and efficacy is dependent on host immune response. It depends on the host immune response. The side effects of regulated interferon include flu-like symptoms, myelosuppressions, depressions, and autoimmune thyroiditis. Other therapies are all oral agents that generally have an acceptable side effect profile even after extended use. But because adipocure and tenofovir may cause nephrotoxic effects, periodic monitoring of renal function during therapy is advisable. Other agents such as lamivudine can cause viral resistance when used as monotherapy. Entecavir also inhibits HIV replications and can cause HIV resistance. So it should not be used in HIV and hepatitis co-infected patients who are not an who are not an HIV antiretroviral therapy. I make it slow because some words is need to be is need to be understood for this. Liver transplantation is considered for end-stage chronic hepatitis complications. Hep B immunoglobulin with lamivudine prophylaxis improves liver transplant outcome with infection rates as low as 10%. Patients with chronic Hep B who are susceptible to hepatitis benefit from hepatitis vaccine. And this is the treatment for Hep B. And we have management, bucket exposure to blood that contains or might contain HBsAg. Following any such exposure, a blood sample should be obtained from source patient and it should be tested for HBsAg. In this case, oral consent is sufficient. The Hep B vaccination status and anti-SBS response status for the ASS should be reviewed. Okay. For greatest effectiveness, passive prophylaxis with HBIV, when indicated, should be given as soon as possible after exposure. Their hepatitis B prophylaxis following percutaneous or pharmacological exposure. Example of employee treatment with source patient is found to be unvaccinated HBIG times 1 and initiate Hep B vaccine series. If negative, HBsAg initiate Hep B vaccine series. Okay. Previously, if the employee is previously non-responder, previously vaccinated non-responder, no treatment, no treatment. Okay. No to non-responder. Okay. Hep B immunoglobulin times 2 or SBIG times 1 plus 1 dose of Hep B vaccine. And it's PSAG negative, no treatment. Response unknown for the employee were tested for anti-HB. If adequate, no treatment. If inadequate, HBIG times plus 1 Hep B vaccine booster dose. And then HBsAg negative, no treatment. So, this is your hepatitis B. prophylaxis following percutaneous or mucosal exposure for the employee. Hoping you understand this, especially the new stuff is included in staff health profile. So I'm now here discussing to help you to understand what is Hepatitis B. Hoping you complete the day and be with me to help to understand what is Hepatitis B. Okay, next. Hepatitis B vaccine. Hepatitis B vaccine. Okay. Our Hepatitis B vaccine virus is available as a single antigen formulations and also in fixed combinations with other vaccines. Two single antigen recombinant. Thimerosal, sorry, thimerosal-free vaccines are available in states. Recon Vivax, Hepatitis B, and Injurex B. Actually, I encountered this uh, way back before I was in charge in the vaccines in the pediatric department area. I always, sorry, I encountered this Recombivax Hepatitis B and Injurex B. Until now, I think we have this Injurex B. You know. Of the three licensed combinations vaccinations of adults, two, and pediatrics B. Pediatrics. Before I all the types of pediatric vaccines, I have record for it for the important is for the year of expirations until when. It's very important. Pediatrics are used for vaccinations of infants and young children. Yes. Twinrix contains recombinant SBSAG and inactivated hepatitis A virus. Seroconversions and detections of protective anti-HBs 10 ml occurs in more than 95% of healthy recipients. Risk factors for poor responses to Hepatitis B virus vaccinations include age over 40 years, hemodialysis, HIV infections, tobacco smoking, improper vaccine storage. Yeah, you said improper vaccine storage. So that's why vaccine must be inside the uh, normal temperature, and there is a we have a mandatory checklist for this vaccine storage. This included the virtual percentage, subcutaneous vaccine delivery, and accelerated vaccine schedule. Persons who are HBsAg positive will also not respond to Hep B vaccine. It could be reasonable to test a non-response for HBsAg cartridge. Dialysis patient and immunocompromised host respond test predicti- predictably and should receive a higher dose at each interval. Serum levels of anti-HBs decline slowly over several years after a successful vaccine series. However, the routine testing for anti-HBs and routine booster immunization are not recommended except in person at risk for a poor antibody response. Who are they? Neonates or immunosuppressors? And then in the high risk of ongoing exposure. Passive immunization. What is passive immunization? I will tell you explanation what is for the additional information. The passive immunization. HBIG is indicated as post-exposure prophylaxis for persons not already immune to Hepatitis virus when they have percutaneous or mucosal exposure to blood or body fluids of a source person testing positively for HBsAg. Excuse me, the course and we're already starting since I think um, almost 1 hour. We already start for almost 1 hour. Because uh, my time is 1 p.m. So I start the lecture at 1 p.m. on time. It was already forward to the quality group. Now, for passive immunization, this, the dose is 0.06 ml uh, kilogram IM as soon as possible after exposure, but not delay more than 7 days. This should be repeated at 30 days if the Hep B virus vaccine series was not begun. Then HBIG is also recommended for recent sexual contacts of all Hep B virus infected persons who are not Hep B virus immunized and infants born to mothers who are Hep B SAG positive. Universal HPSAG testing of pregnant women is recommended to detect all candidate infants for HPIG uh, programs. Hep B virus vaccine is also simultaneously indicated. Just a minute. Sorry guys for the interruption because I need to check what the staff need now for the continuations. Combined Hepatitis vaccinations and HBIG immunotherapy of newborns at risk can prevent more than 30% of prenatally transmitted Hepatitis. Hello? The dose of HBIG for neonates is 0.06 ml kilogram IM within 12 hours of birth. Okay, what is passive immunization? Is indicated as post-exposure prophylaxis for persons not already immune to Hepatitis when they have percutaneous or mucosal exposure to blood or body fluids of a source person testing positively for HBsAg. Next, the Hep C. Hepatitis C. Okay, it helps the what is the Hep B? The last I the last the last after Hep B, next is Hepatitis C. Hep C virus was initially known as non-A, non-B viral hepatitis, which was often seen in the post-transfusion setting. Again, Hep C virus was initially known as a non-A, non-B viral hepatitis, which was often seen in the post-transfusion setting. After discovery of the viral antigens, the virus was named Hepatitis C. Like Hep B virus, Hep C virus is a common cause of cirrhosis and hepatocellular carcinoma. Unlike Hep A virus, And Hep B virus, though no vaccine exists. Treatment for Hep C virus is entering a new era with the burgeoning, burgeoning availability of direct antiviral agents. The descriptions of Hep C virus is a single-stranded RNA, RNA virus in its own genus in the family of Flavivirida. Hep C. This I had question encounter regarding Hep C. They asked this the family, own genus in the family. So Flavivirida. The transmissions. So we are already in Hep C. Next is Hep B and E. Hep C virus is efficiently transmitted parentally by blood injection, injecting drug users. Organ transplantations or transfusion of Hep C virus infected blood or blood products, including clotting factors, and intravenous immunoglobulin, prior to testing blood and blood products in the early 1990s. This story. Risk of Hep C virus transmission was 0.19% per unit transfuse. Per unit transfuse, huh? Since the screening was implemented, the risk is only 0.001% per unit. And then, since 1994, no transfusions associated with Hep C virus transmissions has been detected. The risk of transmission of Hep C virus from an infected patient to healthcare practitioner (HCP) as a result of a needle stick is 1.8%. This is your needle stick injury. There is a high prevalence of Hep C virus among hemodialysis patients. Hep C virus has been transmitted from surgeon to patient, and when safe medical injection equipment or solution protocols have not been followed. Inefficiently transmitted by sexual intercourse, prevalence ranging from 1.3% in North America to 27% in Asia, and long-term partners. Persons with multiple sexual partners and HIV patients have higher risk of seroprevalence for Hep C virus. The average risk for vertical transmissions is 6% overall, and 70% in mothers with HIV. It appears to be related to viral titer. No difference in transmission is noted, whether the child is breast or battlefield. Hep C virus is detected in serum, saliva, urine, semen, and acidic fluid. There is no demonstrated fecal oral or arthropod-borne transmission. Fecal oral where the transmission indicated I mentioned what is in your hyper. A. The clinical features. The incubation period ranges between 15 and 160 days, 2 to 26 weeks, mean 36 to 49 days. Shorter incubations, mean 4 weeks. Is in the transmission through transfused blood products. The patient is usually asymptomatic. Only 24% of patients with acute Hep C virus develop jaundice. Fulminant hepatitis occurs in less than 1%. Fatigue, abdominal pain, and hepatomegaly are the most common clinical presentation. The course may resemble hepatitis virus, but generally is more indolent. Chronic Hep C infection occurs in up to 85% of cases. Of these, 20% develop cirrhosis, average 21 years following infections. 50% have asymptomatic, persistent elevations of transaminases, and 30% remain hepatovirus carriers without evidence of disease. First symptoms may be liver failure or portal hypertension as a result of the cirrhosis. Also, 25% of patients with hepatitis-virus-associated cirrhosis develop, average 29 years following infections. Consumption of alcohol aggravates liver damage from hepatitis and is a significant risk factor for progression from chronic hepatitis to end-stage liver disease. And the other risk factors for complications of hepatitis infections include male gender, under 40 years of age, exposure, HIV co-infection, abdominal LFT, and fibrosis on biopsy. Yeah, this is the clinical course of hepatitis incubation period. This is recovery incubation period. Okay, with business and recovery. This is the pattern of the hepatitis virus infections with percentage. I included the laboratory diagnosis, detection of antibodies of hepatitis virus, the enzyme immunoassay, as evolved as more hepatitis virus protein fragments are incorporated into the current assays detect more than 90% of hepatitis virus infections as early as to 6 to 8 weeks after exposure. Those seroconversions may be delayed up to 20 weeks in 10 to 20% of patients. Sensitivity, sensitivity Bulnaco of testing is approximately 95%, but false positive results may occur in low-risk populations such as blood donors. The reverse transcriptions, PCR, I sorry, PCR, transcription, RT-PCR test can be detect acute SCV infection as early as 1 to 2 weeks after exposure. So I think I need water. The HCV PCR is also used to monitor HCV viral load and its response to antiviral therapies. HCV RNA assay do not distinguish acute and chronic hepatitis, determining the level of viremia is important in gauging clinical response to treatment. So getting a quarantine test is essential. Once the diagnosis of Hep C virus is made, determining the genotype and extent on liver inflammations is important. Several genotype assays are commercially available, and knowing the genotype will guide treatment decisions. Traditionally, the liver biopsy has been the standard tool to grade liver fibrosis based on the extent of the fibrous expansions, presence of Eugene fibrosis, and presence of atherosclerosis. The extent of disease can be quantified through one of several scoring systems. Non-invasive techniques to estimate extent of a liver fibrosis are also available. One such multi-test uses an algorithm based on values of several laboratory markers to arrive at a screening tool that can detect severe liver fibrosis with a high negative and positive predictive value. The treatment. For several years, the treatment for Hep C virus, regardless of genotype, was regulated interval. I think this, the, the standard way to assess treatment response is a sustained viral response defined on undetectable viral load 24 weeks after the end of the therapy. For patients who did not respond to or were unable to tolerate is due to side effects. No real second line option existed. Because of this concern, substantial effort has been put forth in recent years by the scientific community to better understand the Hep C virus viral genome and replications with the goal of bringing to market agents that can be better control viral replications with better tolerability. Interferon plus ribavirin, protease inhibitors approved in 2001. Preventions. Okay. Prevention of Hep C. Avoidance of exposure in the cornerstone of prevention of Hep C virus infection. Uniform applications of standard precaution in healthcare settings should effectively interrupt healthcare associated transmission. Individuals can avoid Hep C virus infection by modifying behaviors that place them at risk. Hep C virus carriers should be counseled to avoid transmitting the virus to others by not sharing razors or toothbrushes, of course. Don't share toothbrushes. And by using condoms for sexual intercourse for those with multiple partners. HCV carriers should not attempt to donate blood, organs, tissue, or semen. Yes. No vaccine available. Post-exposure prophylaxis with immunoglobulin is not effective. Again, in Hep C, post-exposure prophylaxis with immunoglobulin is not effective. Hepatitis D. And after that, Hep A. Hepatitis D, what is hepatitis D, is also known as hepatitis delta agent and was discovered in 1977. I told you when we are more now on more theoretical discussion for this topic. Hepatitis D virus is an RNA virus with the smallest genome of all known animal viruses. Transmissions principally transmitted by percutaneous exposure, but unlike Hepatitis B virus infection, Hepatitis D virus is inefficiently transmitted by sexual intercourse. Perinatal transmission is very rare, and no cases have been documented in the United States. And it's not transmitted by the fecal oral route. Fecal oral route, uh, this is your hepatitis or causal contact. The routes of transmission country in which hepatitis virus infections is endemic and are not always clear. Pathogenesis. I told you. Pathogenesis. What is pathogenesis? This is the manner of development of a disease. Paano nabubuo ang isang sakit? Hepatitis virus infection and hepatotrophism depend on simultaneous infection with Hepatitis virus. As the viral envelope for hepatitis delta virus is the hepatitis B surface antigen. Hepatitis B virus replicates only in hepatocytes and may be cytopathic. I make it slow for that some keywords. Let me, if I talk it fast, I will make bubble. So I make it slowly. Hepatitis virus and hepatitis virus may co-infect a susceptible host. A person who is already a chronic HBsAg carrier can be super infected with hepatitis virus. Hepatitis D. Clinical features. The incubation of the hepatitis virus ranges from 12 to 118 days. Simultaneous co-infection in hepatitis virus and hepatitis virus usually manifests much like acute hepatitis virus alone. However, fulminant hepatic failures occurs more frequently than is seen in hepatitis virus alone. Superinfection with hepatitis virus in a patient who is chronic SBC very often causes more severe acute hepatitis than is seen in hepatitis co-infections. Moreover, hepatitis virus superinfection results in chronic hepatitis virus in greater than 90% of survivors of the infection. 10 to 10 10 to 15% of these, especially among IV drug users, hepatic damage may progress to cirrhosis and liver failure within 1 to 2 years. Be careful, failure within 2 years. Is less common in patients with chronic hepatitis D virus infection than it is with chronic hepatitis virus or hepatitis virus. The reasons for this are not clear. It is it. This is it. Hepatitis virus co-infection. This is the typical serologic course. Okay. The symptoms. Hepatitis virus and hepatitis virus superinfection typical serological course. Time after exposure. Your titer. How does it play this titer? It's the flowchart of time after exposure. It's from CDC. You can check this also on the CDC. And I just put my references every lecture, every topic discussion. I put it my description box the references so that if you need further details for information that you need to know, you just click on my references down and there is a link, some of them. There's a link. The last, hepatitis E. Hepatitis E is a unique among the hepatic viruses in that it carries a particularly high mortality rate among pregnant women. Small RNA virus in the Hepiviridae family, the description. In the transmissions, it's a fecal oral, generally via ingestion of contaminated water. And there is a strong association of epidemics with foods, poor sanitation, poor hygiene. Rare transfusion-associated cases have occurred. Sexual transmission has not been documented. Infection during pregnancy result in a high frequency of fetal loss, and vertical transmissions can occur in up to 50% of cases. The clinical features: this incubation period is between of Hepatitis virus between 2 and 9 weeks in 45 days. And it is generally a self-limited disease that is relatively severe compared with Hepatitis virus. When I'm doing the review of this topic, I always look at all the incubation period from Hepatitis B, C, D, E because I just compare all of them and remember the keywords only. Of course, I cannot memorize them all, so I need to do my own acronyms for it. This is my uh, additional points as you to be reviewed if you have planned to take a CBIC board and also to learn more about the infectious diseases. There is further continuation. There is a prodromal pre-entry phase of non-specific constitutional symptoms, followed by an entire phase that lasts several weeks. Fulminant HIV is rare, 0.54% except in pregnant women. Third trimester occurs at 20%, maternal fatality rate in a 50% during fetal loss. Mortality rate of those infected during the third trimester was 100%. There is no chronic hepatitis or chronic states in human. There is no chronic hepatitis or carrier state in humans with the diagnosis: Hepatitis virus AG, Hepatitis virus IgM, rapid point of care test. Treatment supportive care should be provided as for any of the hepatitis. Fulminant HIV liver transplantation is indicated. The preventions: Hepatitis endemic areas prevention is primarily achieved environmental level by ensuring separations of the water supply from sewage. During outbreaks, when sanitation has eroded, efforts as water chlorination may be inadequate. Boiling or other disinfection of the water supply should still attempted, and avoidance of uncooked fruits, vegetables, and shell fish in this setting. It's also prudent. The pregnant women should be cautious about travel to endemic regions due to elevated mortality risk. Unlike with Hepatitis virus, passive immunizations with I has not been shown to protect against Hepatitis virus transmissions or disease. The standard precaution, again, standard precaution, we always, uh, in our prevention, we always mention the standard precaution, of course, is the number one, are adequate to prevent severe transmission in healthcare settings. The finding of asymptomatic carriage of Hepatitis virus in swine raises concern of send transportation from pigs to humans. The part two, the last topic, HIV. I will only just quick on this topic. I think this is the short one. Last topic. Okay. Studies show that human immunodeficiency virus may have jumped from lymphocytes to human. Lymphocytes to humans as far as back of the 1800. It was first recognized in a man in the United States as early in the late 1970s. This is our story. And then human immunodeficiency virus affects specific cell of the immune system called CD4 cells or T cells, subsequently compromising the natural immune system ability to fight on infections. Acquired immune deficiency syndrome is the stage of human immune deficiency virus when the immune system is so badly damaged that the person develops opportunistic infections and cancers. Without treatment, people who develop acquired immunodeficiency syndrome typically survive about 3 years. Only certain body fluids, blood, semen, percent renal fluids, and breast milk from a human immunodeficiency virus infected person can transmit human immunodeficiency virus to another person. 3 to 4 of all cases are sexually transmitted through having unprotected sex. And globally, more than 34 million people are living with human immunodeficiency virus. Although there is no cure, treatment with antiretroviral medication has improved survival. The use of drug-resistant testing has become an important part of human immunodeficiency virus clinical care. Although historically, vaccines have been the best weapon against the world's most deadly diseases, there is unfortunately no effective human immunodeficiency virus vaccine available. Key components of human immunodeficiency virus prevention programs center on the use of standard application in healthcare setting, risk reduction through behavioral notification programs and medication adherence programs. And the diagnostic test for HIV infection is the standard serologic test. Again, the diagnostic test for HIV infection is the standard serologic test. The most commonly used laboratory test for diagnosis is the serologic detection of antibodies to the virus. The standard serologic test consists of a screening enzyme immunoabsorbance assay EIA, followed by confirmatory Western blot. The last year, no, not last other year, we have a program for screening for HIV for all here, and we do it. And we do it also. After transmission of the virus, most patients develop antibodies at the time that there is clinical resolutions of the acute antiretroviral syndrome. So, if I did not, as I told you, for the additional information you want to know, go on my references that I put in my description box. I do this PowerPoint template yesterday, and I took up one day course to review and update for this preparation today. So, number two is viral load and rapid HIV test. This is the exposure time. We have a small volume and large volume. Class 2 unknown HIV status and source. Then we have recommended HIV post-exposure for percutaneous injuries. The exposure type, the HIV positive class 1, HIV positive class 2, source of unknown HIV status, the unknown source, and HIV negative. This is the graph. We have HIV positive class 1 and class 2. Asymptomatic HIV infection or non-viral viral load. Class 2 symptomatic HIV infections. Source of unknown HIV status. Disease or persons with no samples available for HIV testing. Then unknown source. Thanks. And this is the part 3 of my lecture discussion regarding identifications of infectious disease process. Okay, guys, still with me? Okay, this is the last one. I need to continue it by tomorrow because there is stuff come today to me and they need me to I need to enter the data of some cases like hepatitis for our daily health electronics surveillance network reporting because the data is already in the office. That's why I have a break. And tomorrow is I have another the last topic for identification. So infectious disease processes is I told you by tomorrow I will be discussing the influenza, the healthcare associated pneumonia, and the HP, which is the herpes viruses. And I do it all from the lecture 1, 2, 3, 4. The first and second is the last, I think, last other week. And this topic also can help you to understand the pattern of diseases. Thank you for thank you for watching. And thank you for watching. I'll be right back tomorrow. And by the way, I also have some vlogs that hoping you support it also. Thank you, Bob, from Ron Vlogs and from the Pamilaki Vlog. Nagtatasak today. See you again, guys, for the discussion for tomorrow. My name is Sally from Infection Control Department, signing out for this data. And it will be continued tomorrow. Hoping you will be with me, especially my co-staff, my new staff, my newly hired staff, to understand the infectious disease processes.